Hi everyone. Thank you for tuning in this morning. My name is Cheng, and I'm a fourth-year resident at University Hospital's Cleveland Medical Center, Case Western Reserve School of Medicine. Today, I'd like to talk about the efficacy of an educational intervention on HPV vaccination knowledge and rates of administration. I have no conflicts of interest. Human papillomavirus, or HPV, is a highly prevalent sexually transmitted infection that affects almost all sexually active women. Certain high-risk strains of HPV can cause abnormal changes in the cells of the vagina and cervix that lead to genital warts and cervical cancer. In an effort to reduce HPV infection and these subsequent complications, the FDA has approved 3 vaccines against HPV: Gardasil, Gardasil 9, and Cervarix. Until recently, the U.S. Advisory Committee on Immunization Practices only recommended routine preventative vaccination for males and females from 11 or 12 years of age through 26 years of age. On October 5, 2018, the FDA approved the Gardasil 9 vaccine in males and females ages 9 through 45. However, despite expanded guidelines, HPV vaccination rates remain low. Despite evidence that vaccination dramatically lowers rates of HPV infection and therefore protects against development of life-threatening cervical cancer, stigma and misinformation surrounding vaccination remains high, and vaccination rates remain below the Healthy People 2020 goal of 80%. Moreover, African American and Hispanic youth are less likely than their white peers to have been vaccinated. Expanding parental knowledge, attitude, and acceptance of HPV prevention remain important steps in expanding access to this potentially life-saving vaccination, particularly among underserved populations. Few studies have assessed the impact of an education intervention on increasing HPV vaccination knowledge and rates of administration in high-risk minority women. What studies are available have identified knowledge gaps in this population and show that an educational intervention not only increased long-term retention of HPV knowledge, but also increased vaccine acceptability for participants and their families. We sought to utilize an education video to bridge knowledge gaps in our patient population. The main objective of our research study was to demonstrate an improvement in patients' knowledge about the human papillomavirus, cervical cancer, and its prevention. Additionally, we wanted to determine if an educational video can influence uptake of the HPV vaccine for patients and their families. As for our design, we approached women waiting for their provider during their visits at the resident continuity clinic. After informed consent was obtained, the patients would then complete a pre-video questionnaire assessing demographics and their general knowledge regarding the HPV vaccine. This was followed by a short 3-minute educational video. A post-video intervention survey followed, which included prior questions about the HPV vaccine, their thoughts on vaccination practices, and if watching the video changed their perspective on the uptake of HPV vaccination. This is the QR code that links to our education video. If you are interested in watching, all you need to do is open the camera app on your phone and hover it over the QR code. It should automatically direct you to the video. Alternatively, you can go to the link on the screen. In total, 162 women were approached in clinic. 9 women declined to participate and were removed from the final analysis. 153 women were enrolled. In total, there were 138 completed surveys and 15 incomplete surveys. Looking further at the demographics of our patients, you can see that most were between the ages of 18 to 45. Our patients were primarily Black or African American, and most had gone through high school, if not some college. Most of our patients were in a relationship with one partner. Patient knowledge of the HPV vaccine was assessed with 4 questions both before and after the intervention. As evident in Table 2, The number of correct responses on any given question was higher after the intervention or video compared to before it. There was a statistically significant within-patient improvement in knowledge from pre to post-intervention. In particular, a significant proportion of patients who initially had incorrect knowledge about the pap smear test selected the correct response following the intervention. P equals 0.015. Likewise, patients who did not initially know how many doses are in the vaccine or how long the vaccination series takes tended to select the correct response following the intervention. Both p-values were less than 0.001. For the question, what diseases can the HPV virus cause, with multiple answer choices available, prior to the intervention, 30% of the responses were incorrect, 65% were partially correct, and only 5% were fully correct. After the intervention, however, only 8% of responses were incorrect, whereas 78% were partially correct and 15% were fully correct. A Wilcoxon-signed rank test confirmed that patients significantly changed their answers to be more correct following the intervention. P was less than 0.001. Additional questions relevant to the patients were also obtained. While 69% of women had heard of the HPV vaccine, only 64% had ever talked about it with a healthcare provider, and even less, 59%, had previously received it. There were a variety of reasons for the low uptake of vaccines, with the 3 top reasons being 1, not knowing a vaccine existed, 2, thinking they were too old to get the vaccine, and 3, not realizing they needed the vaccine. A significant proportion of women chose other as the reason for not getting the vaccine, but did not specify further. Pre-video intervention, 56% of women who had not received the vaccination indicated they would be interested in getting vaccinated, whereas 44% indicated they did not plan to get vaccinated. To get a better idea of whether patients' outlook changed following the intervention, we examined the distribution of the post-interview responses separately for patients who either did or did not initially indicate that they planned to get vaccinated. Relatively few patients in both groups indicated that the intervention made them less likely to get vaccinated. However, the groups differed substantially in the frequency of their responses for the other 2 options. The majority of the patients in the group that initially planned to get vaccinated indicated that the intervention made them more likely to get vaccinated, and relatively few of those patients indicated that it did not change their outlook. In contrast, the majority of patients who initially did not plan to get vaccinated indicated that the intervention did not change their outlook, whereas relatively few of those patients indicated that it made them more likely to get vaccinated. A chi-square test confirmed that these 2 groups differed in their post-interview responses. P was less than 0.001, suggesting that the intervention may influence people differently depending on their initial intentions regarding the vaccine. With respect to patients getting their children vaccinated, prior to the intervention, 62% indicated that they plan to get their children vaccinated, whereas 38% indicated that they do not plan to get their children vaccinated. After the intervention, we again examined the distribution of these responses separately for patients who initially either did or did not indicate they planned to get their children vaccinated. Note that only 16 patients had data available for this inspection, as the majority of patients did not answer the pre-interview question. A similar pattern emerged as above. All patients who initially indicated that they planned to get their children vaccinated indicated they were more likely to do so following the intervention, whereas only 50% of patients who indicated they did not plan to get their children vaccinated selected this option again, suggesting that the intervention may influence people more positively if they were already considering getting their children vaccinated. Through this period of investigation, we were able to identify several areas for potential improvement as well as some strengths of our study. Some weaknesses include incomplete submission of the questionnaire that may have been due to difficulty using the iPad interface or the lack of time available to complete the questionnaire during their visit. At the same time, those challenges that we identified also created a more realistic environment. Using the iPad or any electronic interface provided the ease and convenience of being able to finish the questionnaire quickly and incorporate the use of an online video rather than a printed brochure or pamphlet. The use of narration and illustrations throughout the video also may be helpful in reaching people whose health literacy may prevent them from finding written information helpful. Overall, we found that a short video is an effective educational tool to efficiently and effectively teach patients about the HPV vaccine to improve uptake. Our study was able to utilize a different education medium with a higher risk population when many prior interventions utilized written handouts that targeted a more educated population. We also found that educational interventions likely influence patients differently depending on their initial intentions regarding vaccination for themselves and for their children. This information provides us with the tools to continue improving our HPV curriculum for our patients in the future. I would like to thank Dr. Kimberly Gatesy for her mentorship, Jessica James, my amazing biostatistician, and my awesome medical students, Jonathan and Audrey, who spent many hours in clinic helping recruit patients. Thank you very much, and I can take any questions.